welcome. We're welcoming you to the webinar, but if you'd like to chat in where you currently are in the country, let's take a look. We'll do a quick needs assessment here. Syracuse, Oregon, great. Tampa, Montana, Kansas, Florida, oh good. We've got Virginia, Atlanta, Northern California, Iowa, we've got coast to coast. This is fabulous. Wonderful. Texas, Park Ridge, you're close to me. South Africa, oh, I think you get the win for the farthest away. All right, somebody here right in Arlington Heights with me. Alaska, you're coming into for a bit of a distance as well. Michigan, Clifton Park, New York, excellent. Arizona, where you're probably warmer than what I am today. Indianapolis, Calgary, Dr. Lang, of course. Very nice. We've got an international community here with us, and Puerto Rico, very nice. It's fun to be able to see how effectively the new technology that we've gotten used to using for education has been able to draw us together. It's really cool. All right, so I'm showing straight up on the hour, and we want to be very respectful of your time. So I'm going to pull us to order here and say hello and welcome to our webinar on pre-hospital pain management and the evidence-based guidelines for the pharmacologic management of acute pain. This has been a labor of love for the technical expert panel members, and some of them are here today to show you the evidence that we've been able to discover and some of the guidelines that we're presenting to you. My name is Connie Matera. I'm the Administrative Director of the Northwest Community EMS System here in Arlington Heights, Illinois, and I'm pleased to serve as your moderator. We're going to have a wonderful panel of experts with you today that's going to talk about the purpose of the project and our workflow, the 10 Pico questions and our recommendations. We're going to focus a little bit specifically on pediatric pain assessment, our shared decision-making and patient preferences, and the pharmacologic pain management options that we've discovered. And so for just a few housekeeping items here, there's a lot of you. And so part of our Zoom citizenship is that if you're a participant, your Zoom video will be off and you'll be muted, and our speakers will be on camera so that you'd be able to see them. You can miss details if you come to the webinar, because we are making the slide deck available to you. We will be making a recording of the webinar available to you after the webinar is over. If you have any questions as we go through, you can enter them into the chat or the Q&A, and we'll look for themes of that and answer at the end of the webinar if we have time. And if not, we'll create a composite document and issue that in writing afterwards as well. So with that said, we're going to go ahead and get started. So as a disclaimer and in full disclosure, there we go. This whole presentation was produced with support from the Department of Transportation, NHTSA, the Office of Emergency Medical Services, and the Department of Health and Human Services, the Maternal and Child Health Bureau for EMS project through a cooperative agreement. And we're very pleased to say that this is the responsibility of the authors. It does not necessarily represent the official views of DOT or DHSS, but we are glad to have them as partners in this endeavor. Our principal investigator is through the National Association of State EMS Officials, NASEMSO, and we have had a great collaboration with them, and we want to thank Mary Hedges for all the work that she's done with the project through NASEMSO. Our co-investigators are through the American College of Emergency Physicians, ACEP, as well as the National Association of EMS Physicians, NAEMSP. So let's just kind of take a look at the world that we're living in right now. EMS is charged with providing person-centered and evidence-based, cost-effective quality care that improves practice and patient outcomes. We have more change going on now than we've ever had in all of our history. Our dilemma is that in the past, when we look at our history, it takes years to sometimes integrate evidence into the practice, And what we're suggesting these days is we don't have years to figure it out or get some of this incorporated into our protocols. So we're hoping that we're going to be able to flatten the learning curve with this particular webinar and get some of this put into practice as quickly as we can. You kind of think about why this is so important. Long time ago, Julius Caesar said, it's easier to find men who would volunteer to die than to find those that are willing to endure pain with patience. This is one of the things that our patients complain of more than anything. And it's physiological, psychological, and emotionally damaging to the body to be in some severe pain. So we find when we look at our data, right after oxygenation and maybe some ondansetron, pain medication is one of the things that we provide by EMS more than any of our other drugs. But how do we do this in the best possible way? And what we're suggesting is that we need to be able to follow the evidence. And a lot of our EMS medical directors around the country do that beautifully. And in other instances, we'd like them to be able to at least look at what we're going to offer today and see if you'd be willing to put this into your protocol. So we should be analyzing evidence based on its merit, and we should adapt our practice as we find that it's necessary. So I want to introduce Dr. Lindbeck, who is the State EMS and Trauma Medical Director for the Virginia Department of Health. He is our principal investigator for this particular project. And so Dr. Lindbeck, welcome. And if you click, you will start driving the slides.
All right. Thank you, Connie. Thank you, Matthew. And thanks for the introduction. As we move on, Connie mentioned our colleagues at NASEMSO, and I wanted to give a shout out to Mary Hedges and Hannah Dane, who sort of helped keep our eyes on the target and kept us on the rails with this project as it went on. So this is a little bit of an overall diagram of our project. I wanted to make sure people understood that we based this on a previously published systematic review that was done by the University of Connecticut Evidence-Based Practice Center for the Agency for Healthcare Research and Quality. So we had the benefit of the evidence review, systematic review being done, and then working with that very large collection of data and literature to inform us as we work through this process. As you can see, we generated some questions. The original questions were generated from the key questions that were in the AHRQ review, and we added a pediatric Pico question, and Dr. Lauren Brown steered us through that process, and we'll talk more about that a little bit later. I'm going to point out the importance of the technical expert panel here. We were fortunate to be able to assemble a very broadly experienced group in pharmacology, EMS, emergency care, data management, grade methodology to help us through this process. One of the points that we did acknowledge in the manuscript and the paper is that there is some subjectivity built into the grade process. That is designed in, it's part of grade, it's acknowledged as part of the process, but we feel very strongly that a similarly constituted expert panel using the same evidence base and guided by grade would come up with substantially similar recommendations in the end. There we go. So what were our goals with the project here? First, develop a set of evidence-based guidelines, or EBGs, for EMS pain management, building on the AHRQ findings as I briefly reviewed above. We are going to develop some performance measures for pain management, patient care guidelines. We will discuss that in more detail a little bit later, and also develop some educational materials for EMS clinicians, system administrators, educators, medical directors to be able to incorporate these in their patient care guidelines. So what is evidence-based practice? Well, evidence-based practice is a concept, if you will, where we constantly review and adjust our practice to fit the evidence base. It's very easy for us to fall into a comfortable practice pattern based on evidence that we learned at one point and heavily also influenced by our experience in taking care of people. But it's our responsibility, I think, as healthcare providers to back up every once in a while, take a look at new evidence base as it comes along, and be willing and ready to change what we do so that we can bring the very best patient care to our patients. As I mentioned, the Agency for Healthcare Research and Quality, or AHRQ, did this previously published systematic review. We have references available for that if you'd like to look at that, but that is what we based our evidence review on, with the addition of the additional Pico question for pediatrics that we will again discuss a little bit later. So our 9 Pico questions. We got these from the AHRQ review, again, Agency for Healthcare Research Quality, plus our 1 for pediatric analgesia. When we talk about rigorous review methods, we'll expand on this, but we are going to use the grade methodology to define and guide us through this analysis. Sorry, Pico is noted at the top there. That's patient, population, intervention, comparison, and outcome. And again, we'll expand on that in just a little bit and how it fits into the grade methodology. So grade is a system of review. It's a strategy that allows the review of an evidence base and the generation of recommendations. Grade stands for grading, recommendations, assessment, development, and evaluation. And this was the structure that we used and that we followed as we moved through this process from evidence-based and systematic review through the generation of our recommendations. We have 2 papers that we published out of this. One is the recommendations, which focuses on a little bit of background and our recommendations. And Jonathan was the primary author on a very detailed paper that explains exactly how we reach those recommendations, and in associated material gives you a very in-depth look at the evidence base and our decision making. I will make one note that it sometimes can be a little confusing about how the recommendations end up being made. If the evidence base clearly recommends one approach over the other, that seems pretty self-evident. We're going to recommend fairly strongly for one strategy versus the other. But sometimes we're unable to make a recommendation, or we're only able to make a weaker recommendation. Sometimes that's because we have a pretty robust evidence base, but the evidence base doesn't show a strong difference between the two approaches, or there just isn't enough evidence to be able to make a recommendation. And as we present the recommendations, we explain how we reach that recommendation. But sometimes when you first encounter grade and this methodology for making recommendations, it's not entirely clear how we reach those decisions. So what do we want to arrive at the end? What are our objectives? We want to identify and present those major recommendations, explain the rationale. We want to allow people or facilitate the implementation of those evidence-based guidelines for pain management in your patient care guidelines in your agency or your locality. And then be able to explain how we reach those recommendations based on the evidence. All right, thank you. I'm going to turn it back to Connie and Matthew and hand it over to Ash Panchal to carry us further.
So Ash, I didn't even know what to put after your name on this slide because you are involved with so many things. But technically, we're going to put you with National Registry as well as the Ohio State University Wexner Medical Center. But I know you're a medical director, so you're going to lead us out on some of the Pico questions.
Well, it's totally my pleasure. And Connie, thanks for having me here. I think one of the biggest things that as we start talking about this is really, I want to go through the details here. I want to touch base on each of these different recommendations, talk about strength of evidence, guideline recommendations, rationale, some of the caveats to these discussions, just so we can frame kind of what's going on overall and put a bigger picture to what we're doing. Along the way, we'll try to put some survey questions up. And so I'll work with our technical team to try to put those in for you. So with that being said, we're going to get started here in a second. There we go. So our first Pico question is directed at, should intranasal fentanyl versus IV or IM opiates be used for children for the management of acute onset of moderate to severe pain in the pre-hospital setting? So just to give you guys fair warning, this last tagline of management of acute onset, moderate to severe pain in the pre-hospital setting is something you're going to hear a lot, because that is the tagline for every one of our Picos. So you might just get used to that in a little bit here. So when we're talking about this topic, I think all of us understand that the analgesia for pediatric patients is truly challenging in the pre-hospital setting. When we looked at the review of the evidence, there was no significant difference in pain severity scores at 5, 10, 15, all the way to 30 minutes after you gave IN fentanyl versus IM or IV opiates. Also, there's no clinical difference in the undesirable effects of these two management options. Now, with that in mind, when we think about fentanyl administration combined with a non-invasive route of administration, intranasal, we have an excellent opportunity to improve pediatric pain management in the pre-hospital setting. So when the technical expert panel thought about this, we looked at the concept and said that we recommend in favor of IN fentanyl over IM or IV opiates for our pediatric patients. Now, one of the caveats here, which is really important, is this is prior to vascular access or without an IV access point. Now, one consideration is, what do we do after IVs are established? In that situation, you can consider either the IN fentanyl or the IV opiates for an approach. Now, as you're noticing here, what's ending up happening is we have an advantage of this approach, which is to be not only effective, but it also allows us to have an ease of medication so we can actually enhance the amount of treatment which is actually going on in the community. Let's move on now to our second recommendation. So our second area that we looked at was, should IV acetaminophen or APAP, so you might see APAP here tossed in every once in a while, versus IV opiates be used to treat moderate to severe pain in the pre-hospital setting. Now, when we think about acetaminophen, it represents a really promising analgesia that demonstrates similar analgesic efficacy to opiates in our overall review. Now, that was surprising for a lot of people that they were very similar. Now, there is no evidence of any clinically important difference in pain reduction at 15, 30, or 60 minutes, or even in the time to analgesia effect. Now, that's pretty important, but now we have to also consider the adverse effects. And the certainty of evidence was very low, but the evidence did suggest that Tylenol was less adverse than the opiates. So when the technical expert panel got together and we looked at this, again, we had low certainty of evidence, but we recommended in favor of acetaminophen over IV opiates alone if APAP is available, affordable, and easy to give. Notice those little statements at the end. Those are important. Now, one of the reason that's important, and we're going to get into this a little bit more, is that when we look at the rationale behind this, though APAP was equivalent in pain control and is more tolerable than the alternative IV opiates, one of the challenges is the cost of APAP currently, the need to administer by an infusion, which often for us as pre-hospital providers is pretty challenging. And I can say that from my agency, we have the same challenges. Now, one of the things that I think is important here is that it's an exciting step to think about how we can enhance pain in our systems, but it has to be all about whether it's available or not available in our system. So with that being said, let's just ask the question. So here you have on the top of your slide, an easy, nice little poll here. Is IV acetaminophen available to you where you work? Please select one and let's see what we get out of this.
Pretty overwhelming.
So Connie, I don't get to see the results as the speaker. What's the numbers look like?
So right now there's 116 have weighed in. And 21 out of the 117 or 18% have said yes. 82% have said no. So we seem to have many more no's than yeses. So let's go ahead and move on. It is at least an 80-20 split.
Super interesting. I think it definitely puts a little perspective on our thought processes.
Correct. So Matthew will take this down and get you back control of the slides.
That should be back in driver's seat. Let's see here. There we go. Oops. That works for me. So one of the big considerations that I wanted to discuss on this was the fact that these medications do have some adverse effects. So when we think in our review, though there's low certainty of evidence, dizziness was more common in IV opiate groups, but nausea and vomiting was also more common in our opiate group compared to our APAP group. Now, I think we all recognize nausea in general is multifactorial. It affects our patients in many different ways. We induce it in many different ways. And there's multiple mechanisms that our disease process that we manage is going to cause nausea. Now, the best part of this is nausea sometimes is caused just by us driving, right? So 43% in one study showed that people were getting nauseous just from the transport. With this in mind, when we think about the side effects and we put this all into context, a medication like Tylenol, which doesn't have the associated side effects that opiates have, becomes a little more attractive. So something to think about as we're moving forward with our treatment plans. So let's talk a little bit about our third PICO. Should IV NSAIDs versus IV opiates be used for the treatment of moderate to severe pain in the pre-hospital setting? Now, in this evaluation, the technical expert panel compared the use of medications like ketorolac IV versus things like fentanyl or morphine in the pre-hospital setting. Now, for this comparison, the panel suggests that either IV NSAIDs or IV opiates are appropriate for the management of moderate to severe pain. In this review, the panel found insufficient evidence to make any significant conclusions regarding pain severity at 15 minutes, partial or full recovery of pain, or time to analgesia effects. There was no clinical difference in pain severity at 30 or 60 minutes. Now, additionally, upon review of the data, the panel was concerned for low subtherapeutic doses of ketorolac used in some of the studies that were there. So that was one of the things that limited our evidence, but it did give us a good idea of where we wanted to go when it came to the comparison of the two different treatments. Now, with that being said, just like anything else, we did have some specific considerations. So in making these recommendations, we included the concern for a cost difference between the two. However, this is not part of the overall analysis that was conducted. So we did not have specific data about the cost pieces here, but we really took this into consideration as we made our decisions. The other piece is we evaluated adverse events. However, it did indicate that morphine caused more drowsiness and sleepiness and nausea and vomiting also. With these considerations, the use of IV NSAIDs was recommended more attractive as a first line for patients who are intolerant or allergic to opiates, or those who would prefer a lower risk of side effects, or let's be honest, those who wish to avoid opiates altogether. So one of the things that we have to think about is ketorolac is used in many agencies now. So one of the things to think about is what is currently used in an agency and if implementation is feasible, if not already used. So this brings up another question. Which do you use now? We have a nice little choice here. You got fentanyl, morphine, ketamine, ketorolac, NSAIDs, or the elusive other.
So fentanyl is winning so far, but morphine and ketamine and ketorolac are way close, right behind. NSAIDs are trailing, and other is only 7% so far. So 100 people out of 158 have answered. Let's see what else they say.
This is the time where my researcher in me gets going, because I'd love to know what that other is.
All right,
here we
so
go.
You bet. So fentanyl is at 90%, morphine's at 50, ketamine's at 55, ketorolac's at 45, NSAIDs are at 22%, and the other is 7%. Yes, let's like, so I wonder what they're using. But cool. So
Very
fentanyl is
good.
the winner so far.
Well, that's great. Thank you guys for everyone chiming in. That makes it a little more exciting for me on my side of it. So with that being said, we're going to transition now, and I'm going to grab that screen again, and we'll go on to, here we go, our fourth one. Should IV acetaminophen or APAP versus IV NSAIDs be used to treat moderate to severe pain in the pre-hospital setting? Notice this is a comparison of either acetaminophen versus NSAIDs, but we're going to expand on this a little bit in the next slide here. So for this evaluation, the evidence review led by the technical expert panel actually generated two very distinct recommendations, and they're around the concept of route. So the first recommendation, and again, I want to direct you to the low certainty of evidence that we're focusing on here. The first one is a conditional recommendation for IV NSAIDs over IV APAP for the initial management of moderate to severe pain in the pre-hospital setting. The second is for oral, this for either PO NSAIDs or PO acetaminophen in the setting. So I want to take a moment and go through these considerations because I think this is a really important slide here where we really broke it up into our routes about what's the best management here. So let's talk about a little bit of rationale. So when considering the IV route, one study found higher pain severity scores at 15 minutes with IV APAP compared to IV NSAIDs, meaning the NSAIDs are doing better. But the remaining evidence did not demonstrate a significant difference at 30 or 60 minutes or in partial or complete relief of pain. Now, there were few adverse events with both medications by IV. Now, given the cost and the availability differences of both IPAP and NSAIDs, the cost effectiveness favored our IV NSAIDs approach. Now, when we consider our oral route, the panel felt that the route is also an important consideration, particularly since oral treatment could be considered over IV based on a bunch of different things: the severity of pain, resource availability, patient preference, and the bottom line is avoiding completely any use of an opiate. Now, as a pre-hospital provider, we normally think that the approach of IV medications is going to be, okay, we're going to be able to hit them hard and we're going to be able to get that relief in there. Now, the data is suggesting that the rapidity of treatment is very similar in oral and that this may not always be true. Now, in the end, when we really think about this whole thing and we really put the perspective together and we think about our patient population, the panel believed that pain management could be offered to all of our patients as a comfort measure, no matter what our transport interval is. Now, one aspect of this, which is really important for us, is that we may be able to treat more rapidly than the emergency department. And I think we have to be honest about this because there's infrastructure challenges that are built into our systems across the nation that may really delay analgesia as you hit the ED door, getting registered, getting in a room, all those different aspects. And so when we think about the concept that EMS treatment has really a strong potential to improve pain well into the ED stay, as long as we give the medications during our care. So something significant for us to really think about. Now, the last two recommendations I'm going to be talking about here before I hand it over to Jonathan Powell is I'm looking at the concept of ketamine for pain. And I know this is one of those areas which is kind of exciting for us to think about. So when we think about this concept, the first one we're evaluating is IV ketamine versus IV NSAIDs to treat moderate to severe pain in the pre-hospital setting. In this evaluation, there is very low certainty of evidence, so it's driven by really one large study where it demonstrates significant pain reduction at 30 minutes after ketorolac compared to ketamine, but there's no difference at 15 or 60 minutes. Now, interestingly enough, the adverse effects were noted to be higher with ketamine, including kind of the things that we may think about: dizziness, and blood pressure and heart rate increases, but these were not clinically significant. Now, with this in mind, the TEP suggested either ketamine or IV NSAIDs could be used for initial treatment. Clearly, when all is said and done with this very low level of evidence in a single study driving some of this, there's more work is needed in this space so we can get better information on this. Oh, there you go. Sorry about that, guys. A little delay on that from my part. And the last recommendation I want to touch base on is considering IV opioids versus IV ketamine versus IV opioids to treat our moderate to severe pain. Now, this has always been a question that may have asked, and we may have been thinking about, and the TP was really excited to start addressing this and try to actually even look at what's out there to address this question. And so through our thorough evaluation, what we found is there's very low certainty of evidence when it comes to this area. And the TP suggested either IV ketamine or IV opioids could be used for initial treatment. Now, there were no clinically significant differences in pain control at 50, 30, or 60 minutes after we administered with the drug in pain relief or time to effect. There was noted an increased side effect profile for ketamine than opiates, and that was primarily dizziness. But this, again, was based on a very small number of patients in these studies, which makes it really hard to define. Now, one of the things that we really need to think about are some of the considerations about the different medications that we're dealing with here. So when we think about ketamine and we look at the literature, in systematic reviews, there was inconsistent effects across our patients when it came to ketamine treatment. Now, the effect is rapid, that's for sure, and there are many strategies that exist out there, including IV push, IM, or even intranasal. Now, this could well be part of the large variability that we're seeing in treatment effects. Now, additionally, a number of patients in these studies also experience side effects, including commonly dizziness and dysphoric reactions, which we know are common things that we see with our ketamine treatments. In contrast, when we thought about our medications like opiates, we're noted to increase respiratory depression, but this was not significant in our analysis. So with that being said, I think we may have another question for our group here. So do you use ketamine?
Whoop, Matthew, did we lose you?
Let's put that in the chat. That is not a polling question, so chat
Okay.
on in with that.
Great. So I think more than anything else, I think for us, I will go ahead and toss in the chat if you use ketamine or if this is something that you've been thinking about using or the fact. I think based off what our data was before, I think ketamine is definitely well in the running for use, and a lot of us are thinking about it for a number of different reasons.
Lots of yeses and a couple love ketamines. Yeah. Ash, would you be able to just answer one question that we did have is, did we study the use of dilaudid? And I don't think that came up from the series of comparisons that we did.
Yeah, that's correct. That's a great question. So of course, a lot of our evaluations are completely dependent on the studies which are out there, right? What is readily available in the literature? And dilaudid, unfortunately, was not something which was readily available in the literature for us to do the basic comparisons that we're looking at. And so the comparisons that you're seeing in the data here are the comparisons which were identified and most commonly addressed in the literature, and which were selected by the AHRQ systematic review group as the most appropriate questions. So no, dilaudid was not a direct comparison, but of course, being part of the class of medications, which being in the opiate group, you could consider that there is some association with that, but also keep in mind dilaudid as a medication having a longer term effect. It will also change the effects. And also if you consider it in the different characteristics that you have with the dilaudid versus fentanyl, particularly on the effects on hemodynamics, something to consider. Great question.
For those that were asking about morphine and nitrous, hold tight, it's coming. it's coming up.
There's more fun to come, right?
Yep, more fun. So let's move on to Jonathan.
A couple more thoughts here, Connie.
Yeah, we do.
So when we think about our ketamine use, this is based on a continuum of effects from mild analgesia to true dissociative effects. Keep in mind that so much of this is dependent on our dosing. And so that's an important consideration. Another big thing that you have to think about in conclusion is really think about the considerations that you're doing when you think about these medications. A couple of fundamental things come into play. Opiates have been used in the pre-hospital space for decades and have high acceptance rates with our providers and our general stakeholders. Ketamine is increasingly used, as we've noticed in this discussion, and is included in initial training. It is an attractive alternative when we consider patients who are allergic, intolerant, or want to avoid the adverse side effects or avoid altogether any opioids. So when the TP considered these, a non-opioid option may be really good at helping us with healthcare equity, but this was not evaluated directly in this evaluation. With that being said, I am going to pass it over to Jonathan
There we
now
go.
and wash my hands. So thank you guys for indulging me for a little bit.
All right, Jonathan, you are a National Registry Research Fellow and the primary author on one of those very complicated papers. So ready to take it away.
Thank you very much, Connie. I'm incredibly excited to continue this discussion with you all. So let's get right to it. Wonderful. So our 7th PICO to be examined is regarding IV morphine versus IV fentanyl. Now, this differs from our previous adult PICOs in that we are now comparing two opioids directly to each other, as opposed to an opioid and a non-opioid or some combination of the two. Now, after a review of 11 RCTs and 11 observational studies, we suggest either IV morphine or IV fentanyl when treating moderate to severe pain in the pre-hospital setting. See, Ash told you that you would hear it again. There it is. We did not find any significant differences in pain scores, resolution of pain, or time to analgesia. We do make this recommendation in spite of the numbers of studies reviewed with low certainty of evidence due to the differing results in EMS and hospital-based trials. It was noted that morphine has fewer route options and was associated with higher rates of nausea than fentanyl. Now, it may be surprising that we did not conditionally pick one over the other. While morphine and fentanyl are derived differently, they both produce the effects of clinical analgesia with the offset of a depressed respiratory drive, euphoria, constipation, and the potential for physical and psychological dependence. Apologies, I got a little bit ahead of my slide.
That's okay.
Now, we'd like to make sure that you're aware of when you have the choice between these two agents, we'd like you to consider your patient's pain severity, any previous response to opioids, drug interactions, and of course, your own protocols. So I believe we have a question baked in here. So
Here we go.
There it is, wonderful. So which do you prefer? Fentanyl, morphine, and looks like we've added hydromorphone. Good to look at some blood. All right, have we had time to see some results?
We're getting there. Right now, we've got 97 out of 168, so 58%. Fentanyl is out at 81% at this point. Morphine's at about 12%, and hydromorphone is about 7%. I think that probably is going to be the general approach. So yeah. Fentanyl, the leader.
So in our sample, we're definitely looking at fentanyl. Great.
Yep.
So we're going to remove that from the screen and then continue on.
All righty.
All right, so our 8th PICO that we examined regards a combination of weight-based IV opioids plus ketamine versus weight-based IV opioids alone. Now that's a lot of words and can take a minute to wrap your head around it. So again, it's weight-based IV opioids plus ketamine versus the weight-based IV opioids alone. Trying to get it to change screens here.
There you go.
There it is, wonderful. Now, after a review of 6 RCTs and 2 observational studies, we suggest against the combination of weight-based IV opioids plus ketamine versus weight-based IV opioids alone. In these populations, there was a lack of meaningful improvement in pain, an increase in undesirable adverse events, and a clinical desire to avoid the complexities of combining the 2 medications. Now, another combination, IV opioids plus IV ketamine versus IV ketamine alone is our 9th PICO. So again, we're looking at IV opioids plus IV ketamine versus IV ketamine alone. With only 1 observational study to pull from, we're unable to make any recommendation due to the uncertainty of evidence and incomplete information to actually compare the 2 to each other. Now, this means that we have opportunities in the future. So as more research occurs regarding this combination, further analysis will absolutely be necessary. Our last PICO is regarding IV opioids versus nitrous oxide for treating moderate to severe pain in the pre-hospital setting. So we get to answer the question that was seated earlier. With only one RCT to draw on, this comparison has also led to no recommendations being made. Now, similar to before, further information is absolutely going to be necessary to provide comparative evidence between the two medications. And as we know with nitrous oxide, there are some potential cons that we need to consider. Cost, gas replacement, the need for a responsive patient to apply it, all of these things that we need to be considered, and we need more evidence to really make a recommendation. So now we're going to talk a little bit about these recommendations and how they are actually going to fit within our EMS systems. And a big part of this is, why is it important? And it's something that I love to talk about. So let me get on my soapbox for a minute. These comparisons and the rigor that we applied to making them are absolutely critical, and they're important because EMS practice must be guided by all of the available evidence. With pain being a frequent complaint in pre-hospital patients, it's important that the decisions on choosing the most appropriate treatment be made with all available and applicable evidence. In some of these cases, as we've discussed, the evidence just wasn't present and it wasn't there to make a comprehensive comparison. So our next jobs are to identify and rectify these gaps in our knowledge, and it's important to make sure that we fill those gaps, especially as new alternatives to opioids are identified. And so I really enjoyed being able to talk to you all today, and I'm going to turn it back to Connie.
All right, so now it's my pleasure to introduce Remley Crow, who is our statistician extraordinaire. And so Remley, if it's to be known about EMS data, I think you know it. So let's get you control of these slides, and you're going to drive us forward looking at where data should be taking us.
All right. Well, thank you for the kind introduction, Connie. And yes, as the resident data nerd, I would be remiss if we didn't talk just a little bit about what it is we know about analgesia practices from actual EMS data. I'm going to cover three things basically. So first, there are many challenges to providing adequate analgesia in the field. And there has been a lot of really great research about this, some of it being qualitative research on the barriers, particularly when it comes to giving analgesia to pediatric patients. And we are going to talk a little bit more about assessment in pediatric patients in just a little bit. But what do all of these barriers end up leading to? Well, it's probably not a surprise to any of you who are working in the field that pain is frequently undertreated. And in fact, in a recent abstract that I presented at the National Association of EMS Physicians Conference, we found that for patients with emergency department confirmed long bone fractures, roughly half received analgesia. And concerningly, there's a growing body of evidence that suggests that this burden of undertreatment is not borne equally. There's a lot of evidence showing differences in likelihood of receiving pre-hospital analgesia based on patient characteristics, including patient race or ethnicity. And this is after controlling for a number of potential explanatory variables, like what about shorter transport times? What about initial pain scores or the injury types? And so this tells us that we should be mindful of equity in our performance measures related to analgesia and how critical this is. Patient age is another characteristic that is very strongly correlated with analgesia administration. And as you can imagine, the barriers are likely different for this. And we need to explore those. And we're going to talk about one of them again in just a little bit with assessment. So I'm going to move us to the next one.
Yeah.
All right, let's talk about what are some of the barriers. And I know that all of you are probably just bursting with ideas right now. And what is it that limits us from providing effective pain management? Well, there's first of all a traditional reliance on opioid medications. And so only recently have we been exploring a lot of different options, particularly as we're treating patients with conditions like opioid use disorder. There are often other emergent treatment priorities at the moment that could supersede the need for pain interventions. Often vascular access is the way that we're giving analgesia. And so sometimes we have difficulties obtaining vascular access. There's also pressures, competing pressures, I would say. So the need for short scene times or having short transport times. There's this idea, why are we going to delay care and provide analgesia if I'm just 10 minutes from the emergency department? But remember, when we hit the doors, it's not like the magic analgesia people just descend upon the patient and provide pain relief. So this is another barrier that warrants further exploration. And then there's these other complexities. What about paperwork and exchanging the medication boxes? Concerns regarding patient safety. Well, what about accurate medication dosing, and especially in pediatric patients or the elderly? What about the side effects? And can we monitor the patient appropriately? Then, of course, what about drug shortages? How many of you all are facing drug shortages in your systems today? What about the denial of the order from medical control, or I'm going to get criticized as soon as I hit the ED doors? So you can imagine these barriers just go on and on and on, right? And there's so many of them, and there's likely not one silver bullet to fix them all. This is a complex approach to addressing them. But the bottom line here is that we're not always following the evidence. And so when it comes to pain management, practice isn't always aligned with the current evidence. The evidence has evolved and it's going to continue to do so. I always say it's called research because if I knew what I was doing, it would just be called search. And so with research, we often know better after we do some of these studies, and so that we can do better. And a good example of one of these evolving thoughts is around, what about pain medication for patients with abdominal pain, like appendicitis? There was this notion of giving analgesia is somehow going to erase that pain pathway, and we're not going to be able to treat them effectively, or we won't know if their condition worsens. And the evidence says, and probably your anecdotal evidence as well, if you've ever had appendicitis, says that's just not so. And so we know better, we can do better. We can give pain relief when a patient has abdominal pain. The evidence is also suggesting we have some serious differences in analgesia administration by patient race and ethnicity. And that's a really disconcerting thought for us to even just contemplate, that we could have unconscious biases that are going directly against what we consciously believe in many cases, and that could somehow affect care. But the evidence says that we have these differences and that we should be monitoring our care by patient characteristics in our performance measures. And we should look for ways to remove discretion or identify the local drivers as to why certain patients are less likely to receive medication. Does it have to do with communication perhaps, or something else? So you can imagine a host of change ideas here that we could try out as EMS systems that would lead to better equitable care. And so with that, let's take a look at the state of the science. Let's see what types of analgesic medications are being used in the pre-hospital setting. We already kind of did this with our poll, so we can see how we align with the national standards here. Now, this is taken from a 2015 survey of the Eagles. And who are the Eagles, you might ask? Not the band, but the Global Metropolitan Alliance of EMS Medical Directors is known as the Eagles. And this is a group of physician leaders who serve as EMS medical directors for the largest US municipalities. And now there are some global counterparts as well. So they sent out the survey in 2015, and they found out that fentanyl was the most commonly used in protocols, followed shortly after by morphine. And ketamine was there as well with ketorolac, but not as commonly used in the protocols. And so we said, well, 2015 has been a minute, so maybe we should take a look and see where we are, a little bit more current data. We turned to NAEMSE. And for those of you who don't know what NAEMSE is, it is our National EMS Information System. So this is the data standard that all of your EPCRs follow. And most states actually contribute their data to NAEMSE. NAEMSE then makes this data available in an annual research data set, which is exactly what we used here to explore the question of what medications are being given for pain in the pre-hospital setting. We started off with this idea of, we'll just take a look at the pain management protocol. And we found out that it wasn't documented very frequently. And so we decided to run this a different way. Well, what if we just take pains with initial pain scores of 6 or higher, indicating moderate or severe pain, the phrase that Ash mentioned, as our proxy for looking at the denominator here. And so we did this. We found out of those 26 million records, that's a ton, just 911 responses, so no interfacilities, there were 3.2 million patients with moderate to severe pain documented. So like Jonathan mentioned, that's a pretty substantial proportion of the patients we see. Now, only 13% of these patients received analgesic medication. Let's take a look at what medications those were. by and large, opioids were used, followed by, at a very distant 5%, NSAIDs, and then ketamine, and we can see acetaminophen. And so we've talked about why some of this may be, particularly with cost barriers and some of the other things that we've been talking about, but we know that there's also been some shifts. So somebody mentioned it in the chat that generic Offermev is soon to be available, as the FDA has approved a generic medication and the patent for Offermev expired. So this is another area where I would suspect the science is going to keep evolving. And so we should keep our eyes on that and watch the literature. All right. And so that's just a side note there, that the sum is greater than 100% for any of you math nerds like me who are like, what in the world? Because patients could receive 2 or more medications. All right, let's shift gears a little bit more. We've talked about EMS research and data. Let's talk about putting data into action. There is a model EMS protocol that came out of this for pre-hospital pain management. And this will be something that you all can access. Oops, I think I went too far. Take me back. There we go, the NASEMSO website. So you can access this protocol at nasemso.org. It's one of the resources you can download, along with, I saw somebody asked with this presentation. So there's a lot of great resources on this page for you, and perhaps we can get it dropped in the chat as well. But don't jump off just yet. Let's finish talking about this. All right, what is the goal of having this model protocol? Well, our goal is, of course, to ensure patient-centered and equitable care first and foremost. In doing so, it is facilitated by having multimodal options available for EMS to treat pain. And we're talking different types of pain, not just traumatic. So these decisions should always involve the patient and be based on factors like pain severity, the history of the patient, any allergies or any reactions, adverse effects of these medications, and of course, hemodynamic status. So which thing we reach for in our toolkit depends on a lot of complex factors. And that also brings us to the question of what's in your toolbox now, and perhaps the more important question of what should be in your toolkit. And so we have this research now. We should be asking ourselves, what's in there? Do we have a variety of not only pharmacologic, but what about non-pharmacologic interventions? Do we have medications that don't require IV access? We talked about that strong recommendation for IN fentanyl. Do we have opioid alternative medications? And what about things like protocols specifically for something like migraine, where opioid could be related to something like a rebound headache? Do we have clear guidance on when we should be considering pain management? And do we have, really importantly, as your quality nerd here, do we have a quality management program to identify areas for improvement and help us make changes to the system, not to people, to get better results when it comes to managing pain in the pre-hospital setting? And so I could go on and on about this, but I know we have a lot to cover. So I'm going to turn it over to Dr. Brown, who's going to tell us a little bit about one of those barriers that we've talked about, pediatric pain assessment.
All right, so if you could advance your slide, there we go. So Dr. Brown is the Associate Professor of Pediatrics and Emergency Medicine at the Medical College of Wisconsin, and he is our resident peds expert here. So Dr. Brown, are you ready to take it away?
You know, that mute button always gets in the way. At least once during this webinar, someone was going to say, oh, I forgot to mute, and it got to be me. So
it wouldn't be a webinar if somebody—
I apologize for that. So
right,
thank you, Connie, for that introduction. It's actually my pleasure to be here today. As I've worked throughout my career with EMS providers, I've been very impressed with the desire to provide excellent care for children. It's a tall task. Nationally, pediatric volumes in an EMS system usually are less than 10% of your total call volume. And it is really tough to be comfortable with something you do only 10% of the time. This is especially true when it comes to pain management in children. I am a pediatrician by training. Seeing kids is all that I do. And I struggle with this at times. So over the next few slides, we're going to discuss pediatric pain assessment and how to administer, interpret, and respond to the various pain severity assessment tools that are available. Hopefully what I want you to get out of this is always using the right pain assessment tool that is developmentally appropriate for the patient at their age. We'll conclude with just one brief slide about discussing the pain assessment in older individuals with dementia. Let's see if we can get this to move.
So if you click, there you go.
There you go. So to begin with, let's talk about it's important to discuss some commonly held myths about children and pain. First, some believe that infants and young children can't or don't feel pain, and that children across the board experience less pain than adults. While their ability to describe the pain is less than what we see in adults, infants and young children definitely experience pain in the same manner as larger adults. Next, it's common to think that children will readily admit to pain they are experiencing. If you have children, if you have nieces and nephews, you know that children are inherently people pleasers and commonly receive social feedback that encourages them to tell adults what they think the adults want to hear. This may make it less likely for the children to truthfully describe the presence and severity of pain. The myth about children recover more quickly from pain is also not true. The underappreciation of pain in children leads to this myth, and despite the fact that the duration of pain given a specific injury is similar to adults. The final myth is to do with pain management. Many believe that opioids, the most common pain medicine administered by EMS, will always cause respiratory depression in children. All opiate adverse effects are dose dependent, with the incidence of respiratory depression, hypotension, and altered mental status increasing with increased opiate dosing. However, when given a dose appropriate for the child's weight, adverse effects are no more likely in children than they are in adults. So let's talk about pain assessment. Pain is a subjective experience. This means that all qualities of pain can only truly be understood by the person experiencing the pain, and it can be difficult for us as observers to understand pain being experienced by another person. This is similar to trying to describe how something tastes or smells. All available pain assessment tools attempt to objectify a patient's pain experience into a scale that is both understandable and actionable. While not perfect, these scales enable practitioners to assess pain severity and determine the need for intervention. Most currently available pain severity assessment tools, including those available for children, translate pain severity into a numbered scale, with 0 usually being no pain and 10 being the worst pain the person can imagine. Now, pain assessment specifically in children can be very challenging. The classic pain severity assessment tool that we use in our practice is a numerical pain scale, in which a patient is asked simply to describe a number from 0 to 10 that best represents their pain severity. However, this requires sufficient numeracy skills to not only be able to count from 0 to 10, but also to understand the scale of spacing between those numbers. Typical teaching states that children lack these skills until they're at least the age of 8. But studies have shown that even adults may struggle with knowing what number fits their pain best. Because of these issues, separate pain severity assessment tools do exist for children. The main types of pain assessment tools include behavioral scales, pictorial scales, number scales, and descriptive pain scales. So this is an example of a behavioral pain scale. The FLAC scale, or it just simply stands for face, legs, activity, cry, and consolability, is a behavioral scale. This behavioral scales are purely observational, meaning there's no response required from the patient, and they rely instead on visual cues observed by the practitioner. These are typically required in children less than 4 years of age, but may be required in older children who have significant developmental delays. The FLAC scale is performed simply by observing for these specific ranges of reactions seen in distressed children and then totaling the score. For example, a child with an occasional grimace or frown on their face row, that gets them 1 point, is in a normal position and lying quietly, both of those are 0 points, but is moaning, another point, and who is reassurable or distractible, which is another point, would have a FLAC pain scale of 3. This would equate to mild pain, as the 0 to 10 scale applies for mild, moderate, and severe pain. The CHEOP scale, oops, went too far. The CHEOP scale, or the Children's Hospital of Eastern Ontario pain scale, is another behavioral pain scale. And we share this as an example so that you can see that there are multiple validated scales out there, and it matters little which scale you use, so long as you are using a behavioral pain scale in children who are less than 4 or otherwise developmentally inappropriate for another pain scale. Probably the most common pain scale used in children is the FACES pain scale, or one of these pain scales that depicts the faces of individuals with progressively worsening pain severity. These typically can be used for children between the ages of 4 and 12. The patient is oriented to the pictures and then instructed to point to the picture that best represents the pain they're experiencing. Again, the output of this scale, similar to others, is a number on the given range, with higher numbers representing more pain severity. Most of these combination tools, there are combination tools that are also available. They seek to combine the scales to make them multi-purpose and can be used in many different situations. This is an example of such a tool that combines the numerical scale, the FACES scale, a behavioral scale, and what's called an activity tolerance scale. These can be universally applied and are very convenient, but it's very important to ensure that children are responding to the portion of the scale that is developmentally appropriate. So even if this card is used, a 3-year-old, for example, should not be pointing to the FACES scale, and a 6-year-old should not be responding verbally with a number. Finally, there are pain scales that seek to describe the impact of the pain on the child's life and behavior. This is an example of such, called the impact on the patient scale, and provides a brief description of how each pain severity level may look in the child's life. Descriptions include noticeable to tolerable for mild pain, all the way up to normal activities are impaired for higher pain severity. The literacy skills required for this pain scale really limit its use to children who are 12 years and older. Finally, there have been attempts to provide what are called universal pain assessment tools. Again, taking aspects of other tools and combining them onto a single sheet, but also providing different languages or description of those pain severities in different languages, so that older children whose primary language is not English might be able to have their pain assessed. So pain is a subjective experience. This means that the pain severity to which I would ascribe a score of 7 may be different pain severity than yours. This can make interpreting the non-behavioral pain assessment tools very difficult. In 1 week in the emergency department, I saw a 5-year-old with a significantly obvious deformity to his forearm tell me that his pain was a 4, and then a 16-year-old with abdominal pain who rated her pain as a 10 while she was texting on the phone. I know that you all have similar experiences, and it can make your job in assessing the exact severity of the pain very difficult. Determining the meaning of a one-time pain assessment is challenging. However, objective pain scales have been shown to be valuable in trending a single patient's pain over time. Thus, if a child's pain was an 8 but is now a 4, we can know that the pain experience has improved and that the pain severity has lessened. The assessed pain severity is an essential component of determining how to manage prehospital pain, but it is not the only component. It's important that we reconcile the assessed pain severity with other clinical features we observe, especially in children. We should look for visible signs of injury, signs of distress, and the ability to distract, redirect, or reassure the child. Look at the activities and behavior that the child may or may not impact. Is the child overly quiet, apprehensive, or withdrawn? Is there pain keeping them from engaging in age-appropriate interests and activities? These observations, combined with the pain score, will better enable EMS providers to determine how best to manage a child's pain. Similar to children, older adults with cognitive impairments secondary to dementia may require specialized pain assessment tools similar to the behavioral scales used for very young children. The ABI Pain Scale is one such tool. It is based on observations made by the practitioners and caregivers of the change in older patients' behavior. The degree of distress manifested by vocalizations, facial expressions, body language, and behavioral, psychological, and physical changes comprise this pain scale. Please note that this specific pain scale has a range from 0 to 18, with corresponding ranges for mild, moderate, and severe pain that may be different from other pain scales. I am really grateful for your time, and it's been my pleasure to be part of this presentation. And I'll turn the time over now to Dr. Lang.
Thanks, Dr. Brown. So Eddie, you are our resident patient preference person. I was so impressed with the fact that you wanted to make sure that our decision making was always going to include patient preferences and differentiation for them. So ready to take it away?
Yeah, thank you so much, Connie. And I am just so proud and honored to be part of this project and having provided some of the great methodology expertise. So I think what we have learned from this presentation so far is that there are no slam dunks in this evidence base, and that a number of the questions in the PICOs, in fact, the vast majority of them are being informed by low or even very low certainty in the evidence. And as a result, make it a situation where we cannot really make strong or definitive recommendations in the comparison of one analgesic to another. So that's where the part about an individualized or patient-centered approach really bubbles to the surface. And since there are no definitives, the idea is that the approach we're supporting and recommending in the protocol and the model algorithm is to take that individualized approach and do something that is actually maybe something that we don't always think about, but incorporate the patient's preferences into the decision-making process. So pain is a universal experience. We've all had an understanding of what can work and what cannot work. We also know how patients might feel differently about potential side effects of nausea and vomiting. So what the conditional recommendations, which are so prevalent in this guideline, give you the green light to do is to come to the patient and say, you know, we've got a couple of options here. We've got something that's in the morphine family, which will work well, but can make you nauseous. We also have something that is in the Advil family, which will also be able to give you, which may not do that. And let the patient, along with the expertise of the EMS provider, select the optimal decision around a particular circumstance. Also, you want to consider how severe the pain is. We know perhaps that something that is typically renal colic in nature might do better with NSAIDs than with IV opioids, even though we may have been giving them equal footing in our presentation. So what has worked in the past? How would you feel if what we give you will trigger nausea and vomiting? That might be the decision-making, that may be the key fork in the road right there for how these recommendations are going to play out in the field over the next little while. And as was mentioned by Remley and Brooke in the chat and Lauren before me, Dr. Brown and Lauren before me, it's about more than just the pharmacoanalgesics. It's knowing that you'll be there, that you've got tricks up your sleeve, you're going to get them through this difficult and painful situation and safely hand them off to an emergency department. And these things, although they're not included in the HRQ report and not in our recommendations, there are clearly some common sense and valuable interventions, whether it's speaking to the patient, distracting them, repositioning a painful limb, slowly breathing in and out, temperature, and imagining that you're on a beach drinking a pina colada may actually do the trick and lessen your opioid and analgesic requirements. We cure sometimes, treat often, comfort always. The evidence is perhaps even more robust, and we know that some emergency departments and maybe even some EMS units are using really advanced distraction interventions, blowing bubbles, buzzy toys, other kinds of electronics like iPads can make a huge difference to a child who's in distress, and non-pharmacological considerations may be top of the order in this population. So pleased to have the opportunity to present over to Dr. Braithwaite.
All right. So Sabina, we're going to have you kind of bring us on home here with some of the options that are in the new pain management guidelines. So are you ready to click in and take it away?
Thank you, Connie. So I appreciate the opportunity to be involved in this and to share this with you all. This whole project has been a labor of love for all of us, and we really hope that it does help support you in doing a better job or giving you more options in what we provide our patients for pain management. So we do recognize that while what we're presenting here is a buffet of things for you to choose from, we do recognize that the options in these guidelines are not available to all EMS agencies or providers. And that, you know, of course, the caveat that you always hear, you're always required to operate within the parameters of your scope of practice and what your agency protocols allow. But as has been mentioned before, we're hoping that having some of this material out here will allow us to actually give your medical directors some things to choose from when they choose to update their protocols. And so, of course, you like options. And like I said, we have a buffet of choices for you. You got options and options and options. And part of what today's presentation is supposed to do is really help you look at those options and decide where your best option is for your patient population or for your specific patient that you're taking care of in that moment. So some of you know that this is one of my pet things. The rights of medication administration should always be in the forefront. Medication safety should be at the forefront with every medication we give. And since in pain management, we have a number of high-risk medications, including controlled substances, it's all the more critical. So when you look at your rights, obviously the first thing you're doing is looking at your options that you have available to you and saying, which of my pain management options that's available to this patient right now is most appropriate for their painful condition as well as their current physiologic state. So that determination is really going to probably also include an assessment of the patient's pain scale that's already been reviewed, because that will allow you to gauge whether the intervention you provide has actually made a difference. Then, of course, you're going to determine that the patient doesn't have an allergy. You're going to do your independent cross-check to make sure that you actually have the correct drug in hand, the right dose drawn up, and the right route of administration chosen, and that the patient has no contraindications to the drug. Then you're obviously administering the drug correctly and doing a reevaluation for both beneficial as well as positive adverse effects of the medication, and then probably a reassessment of the pain scale within an appropriate interval. And finally, of course, you need to document in your patient care record. So we're going to go through the different routes of administration now, starting with PO options. So if your non-pharmacologic interventions that Eddie just mentioned are insufficient, you may want to consider the use of pharmacologic analgesics. So, of course, this assumes you've already considered and possibly implemented some of those interventions. So first, we have the PO medication options. And while some EMS agencies have already implemented these, some don't for various reasons, including the short transport times that several folks have mentioned, including Remley. And to echo what Ash and Connie said earlier, pain relief really is one of the things we can offer many of our patients. And just because the medication won't take effect for 20 or 30 minutes, or it won't make a difference during the EMS care interval, really isn't a reason not to administer them. So as was mentioned before, these lower acuity patients may sit for quite a while before they get their pain gets managed in the hospital. So really, if we can offer them that for their moderate to severe or even mild to moderate pain, we've really done something for them. So oral options may also be a great option for those trying to avoid parenteral medications or opioids. So our two main options are currently acetaminophen and ibuprofen. And obviously any PO medication is contraindicated for patients with altered mental status, aspiration risks, and inability to protect the airway. And then, of course, every medication is going to have its individual contraindications. And so for ibuprofen, that will include things like peptic ulcer disease and allergy, just like any other medication. We do want you to remember that the PO meds may be part of a layered approach. So like Eddie said, you're having a discussion with the patient. Where's your pain at? What do we need to do? What's your preference? And you may start with one thing, but that doesn't mean you may not layer other things on top of it to really address what the patient's pain concerns are. So if you decide you need to reach for pain management in children, really in kids, one of the big deals is, this is, I think, one of the big deal things that comes out of this. We really need to pay better attention to pain management in children. And we have great options now with intranasal pain medication, and we really want to encourage you to use that intranasal option for our pediatric pain management so we do a little bit better job with our kids. So the intranasal route, we have the mucosal atomizer devices, and that really is the preferred route for fentanyl or ketamine in pediatrics. So if you have no IV access, intranasal dosing is very effective and really should be used. Fentanyl is dosed at 1 mic per kilo intranasally, and ketamine is 0.5 milligrams per kilogram intranasally, with a max initial dose of 25 milligrams. And as was mentioned before, you guys will be able to download this off the NASEMSO website. So don't worry too much about the particulars. This will be there for you whenever you want to look it up. So moving on to intramuscular route, the intramuscular option include things like ketorolac. So that's going to be a one-time dose, 30 milligrams in your IM for your adult non-pregnant patient. And then for our pediatrics, which we consider the 2 to 14-year-old age group, you're giving 1 milligram per kilogram IM with a max dose of 30. Then next option would be morphine sulfate. It's also an IM option if you don't want to start an IV, or you just think it's better the patient's going to need a one-time dose and isn't going to need additional potential titration of medication, that you can do that. So the dose there is 0.1 milligrams per kilogram IM and a max initial dose of 15 milligrams. And then fentanyl, we have 1 mic per kilo with a max initial dose of 100 micrograms. And that's the IM option, not the IV. The IV dose will be lower, and we'll get to that next. And finally, ketamine, 0.3 milligrams per kilogram IM with a maximum initial dose of 25 milligrams. And as was mentioned earlier, this really came to the forefront as one of our better non-opioid options. So really ketamine, I know everybody's heard it in the media and all the things, but from an evidence standpoint, ketamine is an excellent option for pain management. And that's part of what we wanted to share with you all today, is that really is a good pain management option for our patient groups in EMS. Some EMS agencies carry nitrous oxide. There wasn't a whole lot of evidence to look at. It certainly is a good option to consider if it's something that you have available to you already. It is a good pain management option. So nothing one way or another in any significant way, but it is a good option if it is available to you already. Then finally, let's go to the IV route. So we have several options for parenteral non-opioids. And the first one we have listed here is acetaminophen, because as we mentioned, acetaminophen is considered equivalent with fentanyl as far as pain management. And that's a big statement. We've already seen from the surveys that we've done during this presentation, most people are carrying fentanyl, and we recognize that the acetaminophen has been expensive because it has been a brand name. It is now generic, and over the next number of years, that we hope that this evidence-based guideline will help guide protocol development and pain management in EMS. A lot of things will change. As we know, drug availability changes from day to day, cost of drugs changes from week to week. So we wanted to leave this in here as an option for you, especially since particularly the evidence supports that this is an option that should be high on the list, being equivalent with fentanyl. So the adult dose is 1 gram IV, and then pediatrics, you have 15 milligrams per kilogram. Next one is ketorolac, which was already mentioned. You'll notice the dose is lower. If we're giving it IV, it's 15 milligrams IV. And then in pediatrics, it's 0.5 mg per kg IV. And then fentanyl, 25 to 50 mics IV for the adult. In pediatrics, the max initial dose of 50 micrograms using a 1 microgram per kilogram dosing. And then we have 3 more options. Morphine, initial dose of 5 milligrams. For IV, and you'll notice in a lot of these, obviously the doses are lower for IV than they are for IM or IN. And PEDS 0.1 milligrams per kilogram, and I'll just run through the rest of them. The high morphone doses are in there, even though that wasn't within the scope of this EBG because of the evidence in EMS is limited to non-existent. We did want to include that because we know a fair number of agencies are using that. And then finally, the ketamine, which can be either be given slow IV push or as an infusion in 100 milliliters is a nice way to give it so that you don't have complications from that. Then, speaking of complications, you're always going to be aware of your ABCs. So ABCs being anticipate before complications. So one of those, especially for the experienced providers, know that certain medications will cause nausea, potential vomiting in certain patients. And so having your antiemetic ready when administering some of those high-risk medications like morphine potentially is probably a reasonable thing to do, again, to keep the patient comfortable, because there's nothing worse than having a terrible, painful condition and then vomiting on top of it. And then finally, we're going to reassess. Is the patient's pain improved? That's the reason we gave this medication. Did it help? But do we also need to look for potential adverse effects? So is the patient become hypotensive? Do they have altered mental status? Do they have respiratory depression? And because you have them monitored, you'll know those things promptly. So if you're looking for it, just be aware that there are complications to every medication we give potentially, and we should just be kind of have your head on the swivel and be ready for it and be looking out for it when it happens. So I appreciate the opportunity to participate in this project. And I think with that, I'm turning it back over to Connie.
Excellent. So we have really taken a fast flyover of what is admittedly an unbelievably extensive and complicated kind of subject, covering really what was in the Pico questions and then the new pain management guidelines that are within the NASEMSO model EMS guidelines. So I'm just saying we should not be going back. We're not going back to the old days where there's literally only one or two things in our toolbox. We really never want to set our time traveler guide to 2020 again. We do want to be able to move forward following the evidence as it leads us, and being able to manage our patients in a very differentiated and person-centric kind of way. And that's what these guidelines are designed to do. They are all posted for you or will be available on the NASEMSO website. We have teaching tools and materials available for programs that would like to be able to use some of these guidelines and rolling through some continuing education in your own systems. And I think we have a couple of minutes at this point for people that would like to ask us some additional questions, either in the chat or in the Q&A document. Let's see if anybody has something they wish to ask us in chat. And under Q&A, any control studies for pain etiology, especially trauma, there is an enormous amount of pain in the trauma literature. And the management of the pain in and of itself really depends on their hemodynamic kind of situation following the trauma. The one advantage of the ketamine is that it is not going to lower the blood pressure. If anything, it might actually take it up a bit. And it is proven to be absolutely safe, whether you've got traumatic brain injury or other forms of trauma. So there's a whole body of literature evolving in that particular area.
Yeah, Connie, just to elaborate a little bit, what we found was, and the systematic review found this as well, the most common traumatic cause of pain was long bone fractures.
Yes.
The most common medical cause of pain was renal colic, but neither the folks at UConn that did the systematic review or our group felt that the evidence base was strong enough and thorough enough to try to subdivide the etiology of the pain. So we stuck with that moderate to severe pain moniker, but we didn't subdivide it into the etiology of the pain.
Yeah, you're absolutely right. But if they're looking for that kind of literature, they will find it. There is a lot out there, just not under what we had as parameters for this particular project. Anything else that we could answer for folks? Are there some main guidelines to suggest for pre-hospital BLS care, like the distraction suggestions and the oral NSAIDs and acetaminophen? Michael, what I would say is based on the updated education standards as well as the scope of practice model, there are suggestions for medications now that can be given at the BLS level, or where your local EMS medical director may choose to expand scope. So I would send you to those national documents as well as in your own local protocols. And all of those national documents are on the NHTSA website, so www.ems.gov, and you'll find the education standards and the scope of practice model there. Any resources for QA, QI specific for pain management for call reviews? Yes, not specifically coming out of our group, but if you look at, Remley would be able to help you specifically in some suggestions probably for QA, QI kind of studies and pain management. Remley, do you want to field this one?
Sure, I'd love to chat a little bit about some resources for QI and pain management. One of the challenges is that QI projects don't always get published. So that's my first soapbox, is that I would encourage that if you find something that works well, let's find ways to share those, whether that is through full peer-reviewed publication. And there are guidelines for writing up QI projects. They're called the Squire guidelines. So with that, some things that you can do if you're looking to take these on, and we have Brooke Burton in the chat who has done this at one of her agencies, is to use the IHI model for improvement as a framework for digging into these. One of the most useful tools, and the IHI is the Institute for Healthcare Improvement. I know we love our acronyms in EMS, but you can go to ihi.org and get a lot of resources there for free. But the one resource, if I could leave you with one thing to think about, is a driver diagram. And what that is, we start off with our aim, which might be to improve the proportion of patients with moderate or severe pain who receive pre-hospital pain management, whether that's pharmacologic or not. And so we get real clear on that aim. And then we start to dig into what are the things likely driving that outcome? And then even more importantly, what are the things that are driving those things? And so it kind of becomes like this 5-year-old asking why a lot. And we get down to what is the actual root cause. Then the really fun part happens, and you get to try out these changes on a local level rather than just roll something out across to everyone. The thing you start with is, let's test this change on a small scale and see if it works, and then scale up from there. So that would be my recommendation, is take that IHI model for improvement and put it into action. Don't be afraid to try it out.
Excellent. I do want to address Annette Cooper's comments to us about the data not addressing pain, where there's many patients who use a number well over 6, but they don't present this way. This has been the dilemma for EMS since the beginning of time. And ultimately, in most of the literature as it frames out, pain is so subjective, and some folks are unbelievably stoic, and they'll grit their teeth and they'll say, well, it's a 2. And then others, as you saw, are on their cell phone and they're saying, well, it's a 10. And so that's why our assessments have to be just about as multimodal as our interventions. And yet at the same time, what comes through all the time is that pain is what they say it is where they say it is how bad they say it is. And we have to be able to try and reconcile our assessment with what they're telling us. And there is no perfect answer. So I am going to leave that to local medical directors and your protocols to kind of take a look at how many variables do you want to consider before you're providing pain relief. That doesn't mean because they say it's a 10, they get the top dose of opioid that we've got. It says that we should be individualizing this to the comfort level of the patient, and that isn't just the number they're giving us. That's where great critical thinking and problem solving comes in to our clinicians. So I am seeing that we are getting to the end of our time together now. And so I'm just going to kind of offer one last question to the group then. Did anything in today's presentation give you at least food for thought on practice changes that you would consider making moving forward? If you'd like to put that into the chat, that would be helpful. And otherwise, we're going to be grateful for all the work that the panelists and the technical expert panel folks have put into this. And I want to go back again and say thank you so much to all the NASEMSO folks for being our guide through this process. And you can find all of these documents up on the NASEMSO website. And so with that, I am showing that it is time for us to close out our time together. Dr. Lindbeck, would you like to make any kind of final comments as our lead investigator?
Just thank you to everybody, particularly our technical expert panel members who participated in our webinar today. These articles are readily accessible now. They have been open published. So even without subscriptions, you can find them and read them at your leisure. And I'd encourage you to do that.
Excellent. All right, so there's lots of folks still chatting in, considering the NSAIDs and use of the acetaminophen more often. And I would agree for my system, particularly with the IV acetaminophen now coming off patent, this may be a strong consideration that we would like to look at in the future, given the efficacy of that particular drug. So it's an ongoing project, you are right. Education is going to need a lot of frequent repetition and reinforcement with a lot of whys behind it before we start seeing some change in practice. But you have to start somewhere, and I think we've given everybody some great food for thought today. So with that said, thank you all so much for joining us. And if you do have questions, let one of us know, and we will absolutely try to get back to you. And Matthew, I think we can